Good afternoon. Welcome back to Passionate World Talk Radio Network, a wholly owned subsidiary of Global Media Network, LLC. To educate, to enlighten, and to entertain. And this is a shout out to all our listeners. Thank you very much for joining us each and every Friday and listening to our podcast after the fact. We really appreciate your support and hope that you continue listening to the number one talk radio resource content provided that no one else dares to print or to put into audio or video. And now on to the program. On today's episode of Lest We Forget with host Lillian Cauldwell, I suspect some of you already know the return of not the Pink Panther, but of COVID-19 and its variants. So what do we know? What does the scientific community know and the medical community? And let's not forget our ever efficient government and how they will now deal with the new variants of COVID-19. Because they've been keeping records this time about the number of cases of BC before COVID-19 and AC after COVID-19, they know a few facts and stats that they didn't have originally. So let me give you some so you have a better idea. Number one, because of global warming and the effects on Antarctica and the two poles, north and south, viruses and new forms of diseases are beginning to emerge from the snowpacks that were originally sealed and contained by ice. Isn't that a great thought? Well, no longer. The latest mutations of COVID-19 is SARS-CoV-2, specifically KP.1, KP.2, KP.3, and their sublineages. They account for most of the infections that the United States has experienced as of the first week of this month, August, according to Centers for Disease Control and Prevention Surveillance. A combination of this transmissibility of these viruses are getting around our immunity systems and previous vaccinations. And they set the stage for new infections for another summer of COVID-19. Go over to California. They'll tell you all about it. David Montefiore, a doctorate, director of the Laboratory for HIV and COVID-19 Vaccine Research and Development in the Department of Surgery at Duke University School of Medicine in Durham, North Carolina, says, as of October 3rd, the percentage of people reporting positive for the virus has reached its highest point since January of 2022. And emergency room visits and hospitalizations due to COVID-19 have also increased, according to the CDC's data tracker. However, so far, keep your fingers and toes and eyes crossed, deaths remain far below the weekly rates during the previous surges, with 340 reported during the week ending August 3rd, compared with 2,578 weekly deaths during the last COVID-19 peak. In January 2024, and nearly 26,000 weekly deaths at the height of the pandemic in the United States in January 2021. In June, an advisory committee for the Food and Drug Administration unanimously recommended that manufacturers develop updated coded COVID-19 vaccines for the fall, though the FDA has not yet approved any of the manufacturer's proposed formulations. Well, that doesn't help, does it? AAMCN News spoke with academic experts in infectious diseases, virus, and vaccines to answer some common questions we might have about the latest variants and the new vaccines. First question: how are new variants different from previous strains? The SARS-CoV-2 is constantly evolving, but most of the mutations are inconsequential. Montefiore explains, quote, there are many subvariants we don't even hear about. We hear about the ones that are most common at a particular time. Well, that should make everybody happy. The now dominant KP.2 and KP.3 variants, which are part of a family of strains collectively referred to as FLIRT, F-L-I-R-T, because of the part of the virus where they have mutated, are subvariants of JN.1, which is a subvariant of Omicron. Omicron appeared in late 2021 and was the last variant to mutate enough to significantly escape immunity from the original strain and vaccines tailored to it. Since then, the variant mutations there's very little difference, he says, among these variations, and that's a good thing. However, all three of them have escaped immunity up to 5 to 10-fold compared to the XBB variant contained to last fall's booster, 2023. Scientists are most concerned when there are mutations to the virus spike protein, which is what the virus uses to attach to and infect cells. The spike protein is also the part of the virus that the vaccines have been developed to target. The FLIRT variants have several minor mutations to the spike protein, perhaps enough to trick antibodies for a while, but not enough to completely evade immunity. He went on. Question 2, how long are you protected after getting a COVID-19 vaccine or infection? Good question. The authorities said that the antibodies that are triggered from either a vaccination or an infection generally last for 3 to 4 months. Notes Kaswar Talay, doctor, a vaccinologist and associate professor in the Department of International Health at the Johns Hopkins Bloomberg School of Public Health and the Johns Hopkins School of Medicine in Baltimore. The reason COVID-19 cases are increasing this summer is likely because people who haven't been recently vaccinated or infected have fewer antibodies at the ready to fight off the first sign of the virus and more likely to experience its symptoms, including fever, chills, sore throat, cough, congestion, body aches, gastrointestinal issues, and fatigue, which describes the flu virus, for example, and many other common viruses that we have been experiencing before the arrival of COVID-19. In a study by examining COVID-19 infections, hospitalizations, and deaths in Nebraska, for example, after vaccination with the 2023-24 vaccines that targeted the XBB.1.5 variant, researchers found that vaccine effectiveness peaked 4 weeks after vaccination and then gradually waned, particularly as the new JN.1 variant began circulating. Side note, don't get your flu shot too early because the same thing will happen with that flu shot. meaning that if you get it too early, it won't be as effective or not at all effective for when the flu season officially begins. So if you're deciding to get your flu shot around the end of September, somewhere in October, you're in great shape. But if you get it now, not so much. Something to think about. However, he adds that there are greater uncertainties about the effectiveness against hospitalization and death than against infection due to the relatively small number of hospitalization and deaths. So, what are the stats? Well, as of May, only 22.5% of adults in the United States reported having received the updated 2023-2024 vaccination that was released last fall and tailored to the XBB variant dominant at that time, meaning many of those being infected now have significantly reduced immunity to the current mutated virus. Montefiore says, listen up, folks, this is important as in relation to the flu shot. Still, those who have healthy immunity systems and have previously been vaccinated or infected are still less likely to experience the more severe cases of COVID-19 that result in hospitalization or death, thanks to the immune system's second layer of defense, the T cells, which attack and kill infected cells, thereby shutting down the virus production factory. Boy, that should make you feel a lot better, right? Third question, will the new vaccines target the latest variant? Decision makers at the FDA has faced a dilemma when it comes to guidance for producing updated COVID-19 vaccines. Create vaccines tailored to the strain circulating in the spring, or wait to adapt vaccine to a variant that is more likely to be dominant in the fall and risk delaying the production and rollout. In a June meeting, members of the FDA's vaccine advisory toward JN.1, which was dominant until May, are targeted toward one of the flirt variants. And complicating their decision was the fact that Novavax, an American biotechnology company, had already developed a JN.1 targeted vaccine, and the company said it wouldn't have time to change the formulation before the fall. Novavax vaccine is the only protein-based COVID-19 vaccine that doesn't use the newer mRNA technology that the other manufacturers, Moderna and Pfizer-BioNTech, use in their vaccines. It's important to have Novavax as an option because some people are still concerned about mRNA technology, says Mark Sawyer, doctor, a professor of clinical pediatrics and pediatric infectious disease specialist at the University of California, San Diego, UCSD, School of Medicine, and Randy's Children's Hospital San Diego, and a member of the FDA's Vaccine Advisory Committee. Novavax allows them an option to still be protected. Join us next week as we continue to understand COVID-19 and its variants and how it will affect the populace this fall. So stay tuned. I want to thank Ruby, RUBI.AI, for its continued support of Passionate World Talk Radio Network and our subsequent programs. https://esc73.try.rubi.ai, and also for the obstacle of podcast training. with your host and trainer, Lillian S. Cauldwell. And you can find out more about this program and sign up for it, whether you're a middle school, high school, college/university, or just a normal person, or somebody who's done podcasting and wants to succeed brilliantly. Go over to https://education, education.passionateworldtalkradio.com/masterclass. Thank you all for joining me this afternoon. Have a wonderful and drive safely free Labor Day weekend, and I'll see you the first week of September.